Millions are losing their vision to glaucoma, and most don't even know it. But now, new technology can stop it before it starts. From smart lasers to drop-free implants, this is the future of eye care you need to know about.
Hello and welcome to the Dr. Kerry Gelb Open Your Eyes podcast. I'm Dr. Kerry Gelb, host of the documentary Open Your Eyes. If you enjoy our interviews, press like, subscribe, share, and hit the bell for updates on new episodes. Great news! Our full-length documentary is now streaming on Amazon Prime, Apple TV, iTunes, Google Play, and YouTube Movies and Shows. And visit my new website, wellness1280.com, for guest links, resources, and past episodes. And I'd love to hear from you, so reach out to me anytime at drkerrygelb@gmail.com. That's drkerrygelb@gmail.com. So now please sit back and enjoy my conversation on a new paradigm shift in glaucoma treatment with Dr. Nick Bruns. Interventional glaucoma represents a major shift in how we manage this sight-stealing disease. For decades, eye drops were the mainstay of treatment, but now a growing body of research supports a more proactive procedural-based approach, which includes SLT or selective laser trabeculoplasty, procedural pharmaceuticals, and MIGS, which are minimally invasive glaucoma surgery. A new paper in Expert Review of Ophthalmology titled Interventional Glaucoma Consensus Treatment Protocol, led by Dr. Christine Fluke, is among the journal's most ever read, highlighting just how quickly this field is evolving. Today, I'm joined by Dr. Nick Bruns, an optometrist with Summit Eye Care in Milwaukee, a surgically focused ophthalmology practice. He's here to walk us through this changing paradigm in glaucoma care. Could interventional glaucoma become the new gold standard? And what does it mean for the future of vision preservation? Nick, welcome to the Open Your Eyes podcast with Dr. Kerry Gelb.
Hey, Kerry, thanks for having me, man. Looking forward to this chat.
I'm really excited to have you, and I'm really excited about the topic. But let me ask you a question. Why is there a need to change the way glaucoma is treated?
It seems kind of like a no-brainer. You know, the way we have treated glaucoma for decades is let's wait for functional vision loss before we take our next step in our treatment. Or let's wait for something bad to happen before we take initiative and try to help our patient. It's really a reactionary approach. And glaucoma is such a progressive disease. Time is the big variable that we have to take a defensive strategy. So why are we waiting for bad things to happen when we could be more proactive and try making treatments, before negatives happen, before we have visual field loss, before we have functional contrast loss of contrast sensitivity loss? So the need for the change in paradigm, it seems like, well, why have we waited so long to really change this? But now it's becoming much more common. And that's where the term interventional glaucoma, which is such a buzzword right now, that's what that means. It means this change in paradigm, taking it from a reactionary approach to a more proactive approach.
MacuHealth, your science-born and tested solutions for visual performance, macular degeneration, and dry eye syndrome. New products coming soon. Embrace the science.
Let's take glaucoma out of it. And I had a chronic disease, and I go to the doctor, and they say, well, you have to take this medicine every day or two medicines every day. And some you have to take twice a day, and another one you have to take once a day. Or I could do this little procedure, and you don't have to take medicine. It's kind of pretty practical, not wanting to have to take and remember taking medicine every day.
Totally. I think the term procedure is kind of alarming for patients. Patients think of procedure as something that's going to hurt, and it comes with risk. Well, our procedures, part of the paradigm shift, part of the treatment strategy is MIGS. And in the definition of MIGS, minimally invasive glaucoma surgeries, minimally invasive is a part of that. Now, consider that a part of this treatment approach is also SLT or procedural pharmaceuticals. Those are things that come with very little downside and very little pain or discomfort. Patients, I think, are, vision and sight, when we have complications with vision in our sight, patients are in their most vulnerable spot. And they think of that, well, procedure, that seems extreme. That seems like something that I don't want to do. Drops are more of a conservative approach. But from the doctor's point of view, are drops really more conservative, right? Because think about what drops can do. Topical medications or medications, if you're taking for your chronic, hypothetical chronic disease that you're talking about, they come with side effects too. And sometimes the side effects are worse than the disease itself. Back to glaucoma, that is certainly the case. It can be.
So I'm going to back you up just a little bit. We've been talking about it, but if you could define interventional glaucoma for us.
Yeah, interventional glaucoma is the paradigm shift from a reactive treatment strategy to a proactive treatment strategy. So what we're doing in interventional glaucoma is utilizing minimally invasive procedures and surgery earlier on in disease process to try to earlier and more effectively delay functional vision loss. So it's a paradigm shift, proactive rather than reactive. That's interventional glaucoma.
I probably have 500 active glaucoma patients that are on
Mhm.
drops. So tell us about the problems with drops and why drops aren't necessarily the best option.
There's a lot of problems. And I don't want to start off by talking negatively about drops. Drops are still utilized in practice and they're still functional and effective. And I still use a lot of eye drops in my glaucoma clinic. But there are barriers. There's several barriers. I think the first and foremost barrier is just compliance. If you think that your glaucoma patients are taking their drops reliably, man, I got some oceanfront property in Nebraska I can sell you if you really want. They're probably not. And there are numerous studies that talk about compliance issues. In fact, one study said that 45% of patients are taking less than 75% of their recommended dosages. That's a ton. That means a huge portion of your patients are taking far less than what we want, and a very large portion of patients are taking, or a very small portion of patients are actually taking the drops as recommended. So compliance, I think, is the biggest issue. Now, the drops that we have, either whether it's going to be QHS dosing, BID, or TID dosing, that gets you coverage for a certain portion of the day.
Oh,
Now,
and just explain that for the public because there's a lot of people from the public
sure.
that will be watching.
Yeah, yeah, QHS, so one time a day dosing, BID twice a day dosing, or TID 3 times a day dosing. So you can think of that in the terms of hours of coverage. So if you're taking a drop one time a day, you're getting 24 hours of coverage. So the pressure is going to be lowered for 24 hours. Twice a day, 12 hours, 3 times a day, 8 hours. So if you miss a dose, theoretically, right, your pressure is going to be elevated above our target range for that portion of the day. Now, if your pressure is above the set target, that's going to lead to nerve damage and then subsequent visual field loss. So if we're not taking our drops 100% compliantly, most patients aren't, we're having functional damage. Now, add to that, it's not only compliance as the issue, just based on a I don't want to take my drops point of view. It comes from cost. These drops cost money, right? There is a financial burden with that, and that's the U.S. health system. We're thankful for the system that we have. But these drops can place a financial burden on patients, and that's something that really we have to consider when we use drops. And then third, and sometimes most importantly, the effect that the drops can have on the ocular surface. In my world, I work in a world of well, glaucoma for sure, but also premium cataract surgery. We do a lot of multifocal lenses, a lot of premium advanced technology, IOLs and LASIK and ICL procedures. So the effect that these drops, the preservatives incorporated in the drops, the medication itself, what it can do to the ocular surface and how it can impact visual function just from a dry eye point of view, it can be pretty dramatic and it can really impact a person's visual performance. So we're trying to treat something to reduce the effect of a potentially devastating disease with something that can in itself harm vision. And you just kind of take a step back and think about that. Well, why would we do that? Why wouldn't we do something that could be more proactive, less burden financially? There is an upfront cost oftentimes for procedures, and we get billed that to the medical insurance. But from these procedures in MIGS, they last a certain amount of time, if not forever, right? We're taking that burden, putting it all up front, which is very minimal, relatively speaking, We're taking the burden away from the ocular surface, and now our patients don't have to be compliant. We're utilizing technologies that have 24/7 coverage. The patients don't have to remember to get up to use their drops. They don't have to remember, oh, that's right, I forgot to pick my drops up from the pharmacy. That is all done with one simple procedure, whether it be a MIGS or a pharmaceutical procedure or a laser. Those are ways that we can help the burden of our patients.
I think the issue of compliance is very, very interesting. There was a study done with people who have had heart attacks, and they were in the hospital for over a week, and they have all kinds of IVs hooked up and monitors hooked up to them. And a year later, only about 50% of them were taking their medication for their heart the way they were supposed to. So if they're not going to take their medication for a heart attack a year later, half of them, there's a good chance that they're not going to be compliant taking eye drops, even though they know that glaucoma could cause blindness. And there was a study done with, they put a little chip in the bottom of the bottle, and about 50% of the people weren't taking their drops on a regular basis. But most patients will take the drop the day before they come and they see the eye doctor. You know,
Oh yeah, yeah.
they want to get a good score. And you talked about, dry eye, ocular surface disease. Over 70% of the people who are taking drops do experience some type of ocular surface disease. And dry eye disease or even ocular the surface disease is a good predictor of compliance. So,
Mhm.
if they're going to have dry eyes as a side effect, it's going to drop compliance up to about 20-25%, which I think is very interesting. And I'd like for you to talk about medication stacking. About half of the patients that have glaucoma are on more than one drop. And if you
Mhm.
could talk about that, and how does that affect being compliant?
Well, it's a challenge for a lot of the reasons that we already were kind of touching on. I mean, medication stacking, they're going to have interactions. And again, it's the big thing that you're going to have is issues with the ocular surface. And I like the point that you made, Carrie, that patients oftentimes when they come in to see their doctor, they will use their drops on time and oftentimes more often than they should be. It's kind of like when I go to the dentist and I floss my teeth 12 times the day before. My gums are all bloody because I wanted to floss away the cavities, right? You want to impress your doctor. You want to be on your doctor's good side. You don't want bad news. And that's just human nature. So medication stacking, our patients have to use their medications as prescribed. So what that means is, let's say we have two medications that are dosed twice a day. We're taking them in the morning and in the evening. Well, really, you should wait a certain amount of time in between each drop, right? You should wait at least 5 to 10 minutes in between each drop to allow proper absorption into the ocular surface to get the maximum efficacy. What inevitably happens, patients don't do that, right? They will put a drop in and then boom, they'll put the second drop in right away. Now, what happens when you have that much liquid in the eye? The eye can only handle so much liquid. So a lot of that is going to end up running down your cheek. You're not going to get the medication in the eye where it needs to be. And so that can be a significant barrier. But do we really expect our patients to wait that amount of time? We expect that. Do they actually do it? No, no, they don't. And, one study, speaking of compliance, I mean, one study did suggest that patients were 25 to 30% self-reported non-compliance. And that's just the tip of the iceberg. I mean, 25 to 30% patients self-reported non-compliance. It's probably a lot higher than that. And if you take into account the way patients take their medication, when they stack them and they use them back to back, after just a few seconds in between, that itself is non-compliant, right? And so that is going to impact things too. So 25 to 30% is really, I think, the low end of actual non-compliance. It's probably a lot higher than that.
And there's also periorbital fat atrophy. So you
Mhm.
talk about that and how it could change somebody's appearance.
Yeah, prostaglandins are notorious for that. And a lot of patients, prostaglandin drops are a lot of times first line in topical treatment because of their ease of use. They're dosed once a day. They're usually relatively cheap and they come with very few side effects. But the downside to them is long term, you might develop pigmentation of the eyelashes, which for some people that might be a good thing. But you might have atrophy of the eyelids and then pigmentation around the eyelids as well. So let's take that into account if we have somebody who's only taking a prostaglandin analog on one eye. Well, then you've got this sort of lopsided asymmetric appearance. And that can cosmetically be a reason for somebody to not want to take their drops. I understand that. I get that. If you're taking it bilaterally, sometimes I walk into a room and I can tell who's been on a prostaglandin for how long, just based on their appearance and how their eyes look. So that can be just a cosmetic reason for somebody to not want to take their drops.
And how about the advantages? You started touching on the advantage of interventional glaucoma, whether it's SLT, MIGS, or one of these implants, sustained release implants of medication that are actually put in the eye. So talk about some of the advantages.
Yeah, we really had the light trial, which was published a few years back, highlighting the effectiveness of SLT. SLT is a simple, very non-invasive laser procedure that we do in the office. It's quick, it's painless, it's very effective. And basically, what the light trial said was that SLT as a first line therapy is at least as effective as topical drops as first line. So if we think about our goal with glaucoma, first line goal is to get the pressure to drop by about 30%. We kind of want that as our benchmark, right? If I can accomplish that with a simple one-time laser procedure, why don't we consider that? Now, our patients who are phakic, our patients who have cataracts and they're ready for cataract surgery, we have the option now to place a little stent at the same time as cataract surgery, and again get the same amount of efficacy as a single drop would get us, right? So if I tell my patients, I have this conversation daily. Well, hey, Mrs. Jones, we are going to take your cataract out. We're going to make your vision better. We might get you out of your glasses, which is two birds with one stone. And hey, third bird, same stone. What if I told you we could potentially reduce your burden of the eye drops? What if I told you that we could maybe get you to a point where we wouldn't need these eye drops? You're already on the table. You're already having surgery. The procedure takes just an extra couple minutes. It comes with very, very little risk. There's really not a whole lot to lose. What would you say about that? And almost always it's, well, yeah, sign me up. Why wouldn't we do that? You're right, Mrs. Jones, why wouldn't we do that, right? Let's take advantage of that time. You're already under anesthesia. You're not going to feel anything. Let's take advantage of that time while we're doing it to potentially reduce your burden on the drops. And it really just makes sense. Now, again, I'm not a surgeon. I don't do these procedures, but I do manage them very, very routinely. It seems like a very simple thing. It is a very simple, relatively speaking, procedure to do. And again, I can't speak as a surgeon. I've never done one, but it is rather straightforward relative to the other procedures that our ophthalmology colleagues are doing. And so again, taking advantage of the time while the patient is there, it just makes sense.
And would you say there's a delayed visual field loss doing interventional glaucoma versus conventional treatment?
Absolutely. Absolutely. So that's the thing with functional structural damage versus functional visual performance, right? So what happens, we lose nerve fibers with elevated pressure. If our pressure is above where we want it to be, we are losing RNFL. We're losing retinal nerve fiber layer. What happens now, there's a lag time. There's a lag between the structure loss to the functional vision loss. Now, we don't know, that can be highly, highly variable depending on a number of factors, the patient's age, race, gender, different factors, and what type of glaucoma they have. But we do know that there is some lag. So with traditional methods, we are waiting until we have functional vision loss. Now, the structure loss has already happened. It's still actively happening. So we're trying to basically get water out of our boat as it's actively sinking. And that sometimes can be a very, very big challenge. Now, what if we just plug the hole before it happens? If we start seeing problems structurally, let's do something about it there. Then that lag time still exists. We'll still see functional vision damage down the road from what has already been done, but it won't progress. And that's the point. So we're taking this treatment, moving it forward in the patient's timeline, months to years. Glaucoma is a disease of progression, right? It's a disease where it progresses. We can't undo the damage that's already been done. So being proactive it's of utmost importance because what is done is done. Vision is lost. We can't undo it. So trying to get the water out of that ship that's sinking, it can be a really tough task. And that's kind of, again, why the paradigm shift is happening.
Depression, that people that are taking eye drops tend to be more depressed than if they don't have to take eye drops at all.
Yeah, that makes sense to me. I think there's a mental burden here too that we're probably not highlighting as much because the need to take drops, it's a constant reminder that, hey, I'm sick. I've got to take these drops because I'm sick. The real struggle with glaucoma is that it's a disease that, especially in its early stages, there's no symptoms. And so it's a reminder, hey, I'm sick, but I don't feel sick, but somebody's telling me that I'm sick. And for me as the doctor, and you too, Carrie, that's a tough conversation to have. I don't know how you deal with it with your patients, but it's a challenge to convince patients that you do have a problem. You don't feel like you have a problem. And all I'm doing is providing negatives for you. I'm just telling you here, we have to do this treatment and reminding you that things are not perfect. And that can take a mental toll on people. I don't know. What do you think about that?
Yeah, I mean, I agree. You have somebody that's coming in where I'm dealing with in primary care. By the time they're seeing you in your clinic, the wheels are off the bus. A lot of times you get referrals. For me, I'm seeing primary care. So somebody's coming in for glasses or contact lenses or just a routine te examination. And I have to tell them, well, your pressure's 35 or your pressure's 30. We're going to have to prescribe medication for you so you don't go blind. And it's like, what? You know,
Hmm.
I just came in here for eyeglasses, and you're telling me that I could go blind. So it can be a very difficult conversation. So, we have to use a lot of different types of tools and show the patient what they have, show whether showing them that their optic nerves could be abnormal, showing them the images compared to a normal optic nerve if their optic nerve happens to be abnormal, or their optic nerve is normal and they have ocular hypertension and they don't have any OCT findings or visual field defects, but their pressure's 35 and they have to be put on medication or they have to have some interventional procedure.
I think that's the interventional mindset really has to be adopted by the primary care optometrist. I think it really does. By the time patients come and see me, we're a secondary care. We do surgery. Damage has been done. There's a lot of things that I wish we had done sooner. And again, that's not really my area because we're seeing patients as they're referred in. And a lot of people, I think if you ask a lot of people just on the street, you know, do you go to the doctor every year? Do you get your annual physical? And I bet not a lot of them would say, yes, I do. And I bet the reason is that they don't want bad news. I think at the really, really root of just human nature, we tend to be averse of bad news. And that makes sense, right? We don't want bad news. I just go to the doctor and they're going to give me bad news. They're going to tell me that my blood sugar is too high, or I'm overweight, or my blood pressure is too high. Or I'm going to go to my eye doctor and they're going to tell me that my pressure is too high. But I think the average individual looks at a primary care optometrist for, a good thing, right? Most people don't go to their optometrist and get bad news. They go to get help. They want to see better, and we can provide that in a very, very comfortable setting in primary care. So I think this interventional approach, we've got it in our clinic, but it really needs to extend out into our primary care, our primary care colleagues. And here in Milwaukee, we have a really good network, and we preach this all the time. Be interventional. You know your patients better than I do. You know these people, right? You see them every single year or multiple times a year. You know them better than I do. So I don't want the patient to come into my setting where we have a lot of, shiny, fancy gadgets. I don't want them to be intimidated. And that can be really, really challenging. It can be a really, like I said already, I mean, people are really vulnerable when they have eye issues, and they come in sometimes to our clinic and they're very nervous, and I can just sense that right away. But if you plant that seed that, hey, yeah, this is a problem, we do need to get it addressed, but we can address it in a very comfortable, safe way with really, really low amount of invasiveness, really low risk profile. This is a good thing. It's good that you came in and it's good that you get checked out every year. Let's preserve this. And again, glaucoma does have a genetic component. Let's get your family checked too.
Right. It's interesting that you bring up some good points. And there was a study done. It takes 17 years for new research to be adapted in the clinic by physicians.
Hmm.
So, I mean, 17 years is a long time to get these things to a change, to have a paradigm shift. So that's why we're doing a podcast on it so people could get educated and say, well, maybe there's a better way for me. Everybody's different and care is individual. And Mrs. Jones and Mrs. Smith, maybe Mrs. Smith, it's best just for her to be on drops because of her lifestyle. And But Mrs. Jones with exactly the same thing, interventional would probably be could be a much better approach, and she doesn't have to worry about taking drops. And
Mhm.
she could take care of it. One, two, three. See her optometrist or ophthalmologist every 3 or 4 months, as the typical protocol that they would see if they were taking drops, and be treated. What do you how do you feel about that?
Yeah, it's an interesting conversation. I think, the other thing about the interventional glaucoma mindset, things in eye care tend to start in ophthalmology, right? And then they kind of trickle down, right? They trickle down into, my area where the secondary care, then into primary care. And interventional glaucoma is still not adopted by all ophthalmologists. I mean, there are a lot of ophthalmologists, cataract surgeons who aren't doing minimally invasive glaucoma procedures. There's a lot of them. And I don't quite understand the hesitation. Why wouldn't you offer this to your patient? Why wouldn't you take advantage of the opportunity? If we could reduce this burden on you, why don't we take advantage of that? So it does start there, and that's where the paper that had referenced earlier, the interventional glaucoma consensus treatment paper that was written, that's where it was written. It was written in ophthalmology by glaucoma specialists. Now, glaucoma specialists, yes, they are going to have the interventional mindset. That's where it starts. But then it has to extend out. And if we're still not at that point where even general ophthalmology has accepted it as standard of care, from my point of view, it should be standard of care. We should be offering now, whether it is an iDose or an iStent or a Hydrus or an Omni. There's so many different things that we can do, and everybody's got their own flavor of choice, right? What they're comfortable doing, what they're comfortable managing, and what they're comfortable performing, and that's fine. I think the important thing is to get on board with this as a general mindset and be more aggressive with non-invasive treatments. And that starts in ophthalmology, and then it really has to extend out into our referral network and primary care.
And I think it's really important that people remember, that topical therapy does not necessarily prevent vision loss. There was a 20-year study done by the NIH, Olmsted County study, that showed even with taking drops, 13.5% of people develop blindness in one eye and 4% develop blindness bilateral. And these are
Mhm.
people, whether it's because they're non-compliant or whatever the reason, they are on drops, but 13% of them, a little bit north of that, still have gone blind in at least one eye, and 4% in both eyes. And then there was a Swedish study. We measure people to see if they're getting worse with glaucoma with visual fields, which is a side vision test. For people that have been to the eye doctor, they know they sit in this big Ganzfeld and they're pressing a button. They're seeing if they can see the lights off to the side. And there was a Swedish study, even with treatment, the average person was losing almost a decibel a year, zero point 0.8 decibels per year, and 5%, a little north of 5%, we're losing 2.5 decibels per year, even with treatment. So it's not like they're equal. It's not like it's equal. And I would like to see if you could comment on that.
Yeah, I know the study you're referring to, and I think it proves that glaucoma, while we know a lot about it, we certainly don't know everything about it. We don't really know exactly what causes it, at least primary glaucoma. We don't really know. There's a genetic component to it, but we don't know why person A is going to get it and person B doesn't. We know how to control it, but what we're controlling is really a variable. It's eye pressure. We're controlling an indirect variable on what the actual problem is, which is RNFL loss, optic nerve damage. And that's what we know. That's really what we know. And I think that study highlights the fact that even though we think we're doing a good job, those patients in that study, they were on drops. The doctors, we're making at the end of the day a bit of an educated guess. When I have a patient coming in, their pressure is X. Let's say it's 25. They come in and yeah, Mr. Smith, your pressure's at 25. I look at all of the pieces of the puzzle that I have in front of me. We're looking at their visual field. We want to see if they've had functional loss. We're looking at their OCT. We're looking for structural damage. Looking at other variables like their pachymetry, hysteresis, how is their cornea reacting? That gives us an idea of how well their eye can stand elevated pressure. And then, of course, their pressure itself. And we measure that several times, usually on an initial visit. So let's say I have a patient, they come in for an initial evaluation and their pressure is 25. Well, with 25, no significant damage on the visual field, RNFL that's consistent, an OCT, a scan that's consistent with glaucoma, and everything else is kind of telling me that, yes, this is glaucoma. My initial thought is try to get the pressure around 18 in that patient. But what we don't know is 18 really low enough? We have no idea. Really, I don't. We think based on the Oates trial and various other studies that that is kind of a good benchmark, but we may find that that's not low enough. Or we may find that that's plenty low. Or we may find that this patient doesn't actually have glaucoma at all. And all of these pieces of the puzzle are kind of leading me down the wrong path. So glaucoma is a disease where it does take time and it takes repetition of testing. So that visual field test that you talked about, everybody hates doing that test, but it is really valuable because it is providing us an idea of where things are and it is really guiding what my next step will be. So in that study you referred to, where I think it was 13% of patients had visual field loss, right? The doctors, that tells me that the doctors taking care of those patients, 13% thought they were doing a good enough job, but ended up being wrong. And that's not an indictment on the doctors at all. That is just a testament of how tough glaucoma really is. Now, you add to that the human element, the element of the patients, the 13% of patients that had visual field loss have to be compliant. And that's tough. That's like telling my 4-year-old that, hey man, you gotta eat your spinach because it's gonna make you big and strong. He doesn't like spinach. Of course he doesn't like spinach. It's gross. Patients don't like taking eye drops because it stings or it hurts or it causes visual problems or it costs them money. So 13% of those patients that were what we thought being treated properly ended up not being treated properly. So take that human element out of it. And that I think is what interventional glaucoma is. Let's take the human element out of it. Let's be interventional. Let's be proactive. And I think that's really that study that you referenced. I'm very familiar with that study. And it really, I think, highlights exactly what interventional glaucoma is.
With more screen usage and indoor time, myopia, also known as nearsightedness, is increasing and getting worse in children. Now, certified eye doctors can prescribe MiSight One Day, the first and only FDA-approved soft contact lens to slow myopia progression in age-appropriate children. Visit CooperVision.com to find a Brilliant Futures certified eye doctor near you. Glaucoma is so tricky because you don't know who's going to lose vision, and with the same treatment, the same drops, the same pressure, you don't know who's going to lose vision and who's not. You just can't predict it at the beginning. If they all start in the same place with the same optic nerve, about the same visual field, about the same OCT. I'll give you an example of a patient. This patient came into us and he was told by his last doctor to take drops. And he decided he wasn't going to take the drops. And in 1 year, he lost his vision in one eye. He went blind in one eye from glaucoma. Luckily, he didn't go blind in both eyes. He still had vision left, but he needed end-stage surgery where he needed a filter. And for those listening, that's the end of the rope for glaucoma surgery. And he always, every time he comes in, he's so mad at himself for not being compliant and listening to the doctor. But I want to talk. I want to dive deeper into the different types of interventions that we could do. Let's start off with SLT, and you did talk about it a little bit. How normally it lowers pressure about 30%, but there are people that SLT doesn't work on. And tell us about the pros and the cons of SLT.
Yeah, the pros are pretty simple. It is quick and it's safe. It takes a couple minutes, maybe not even. It is painless to go through. I think the most uncomfortable thing is you have to use what we call a gonio lens, which is a lens that kind of holds the eyelids open, and that can be, I guess, a little bit uncomfortable for patients, but it's not painful by any means. And it's effective. I think the biggest thing that I like about it is that it's just very, very effective. It lasts. The other part of SLT is that it can be repeated. So some people respond better than others. People with higher pressure tend to respond a little bit better. People with a little bit more pigment in their eyes tend to respond a little bit better. And so the length of time that it is efficacious, that it's actually working, can be about 5 years, give or take. Some people a lot longer than that. But if we start to see pressure creeping up, we can redo it. And it can be effective up to 3 times, or sometimes even more than that. Every time you do it, it tends to lose a little bit of its effectiveness. But we like to use it as our first line therapy. Now, the cons to it, well, sometimes it doesn't work. There are a couple patients where it doesn't work, and that's just a part of surgical eye care, although it's not really surgery. Technically, it's a procedure. Other than that, I don't have much downside to it. I really don't. I think SLT is it is always something that I bring up for any patient coming in with any glaucoma design. I always bring it up. I think the term, it is a laser, and I think that idea again, it's a procedure. Patients get nervous about that. They think it's a procedure that sounds big, it sounds scary, it's gonna hurt. And I always really try to downplay that because it is not big, it is not scary. We have it in the exam room. It's under a sheet in our office. I always point to it. It's like right there. We can literally, it's right there. We do it all the time. This is not a new thing. It has been around for decades. We've had SLT for a long time. We had ALT before that. So it's not a new concept, but I think the fact that patients still respond as if it's new is it's kind of showing that this more interventional approach is still kind of foreign, and it's very foreign to our patients. I didn't have our patients all the time. They come in and they start talking about, well, I didn't have a friend who's had this. They always reference their friends or family. Well, none of my friends or family have had this done. Or they may say that I had a friend who had LASIK, right? LASIK is that sexy word that everybody knows, right? And their vision was great after LASIK. And I have to remind them that this is not a visual thing. We're not making your vision better or changing it by any means. What we're trying to do is prevent your vision from getting worse. And so it's really important to educate our patients when we talk about SLT that this is very different from LASIK. This is very different. LASIK is a surgery. This is not a surgery.
One of the downsides I've seen from SLT or the laser procedure is I've seen this happen a number of times, at least in my area, where they'll go in, they'll have the SLT, and the ophthalmologist or the glaucoma specialist will take them off all their other drops. And they had their SLT, they won't need their other drops. Now, typically, these are people that have been on maximum medication, and now it's time to add another medication, but there aren't any more medications. So instead of the medication, they're getting the SLT or the laser treatment, and then they take them off all the other drops, and the patient comes in and the pressure is 38. And I've
Yeah.
seen that happen a lot of times.
That's not necessarily good practice. You got to be careful. So again, it doesn't work for everybody. So when you do an SLT, it can also take a couple weeks to kick in. It's not going to work overnight. It's not like if you have your laser done today, tomorrow your pressure is better and boom, glaucoma cured. That's not how it works. You do have to have the patients back. It can take up to 6 to 8 weeks for you to get a real true effect, at which point you can start considering, depending on your strategy. Some people take drops right away. Some like to wait. I kind of like to wait to see how things respond, and then remove drops one at a time because the laser effectively should take the place of one drop. It probably won't unless you have, some people are super responsive and that can happen. But just on average, it should take the place of one drop. So take one drop away, see how the patient does. And again, time is our variable. Monitor, repeat visual field as much as they hate it, repeat that visual field, repeat scans, see how we're doing. Make sure that there's no progression from point A to point B. If we're doing better than we expect, then take that second drop away. You can toy with it. This is a puzzle. Sometimes in puzzles, you got to try different pieces and rotate them around to see if they get them to fit. And that is a part of this process. That's why I love glaucoma. It's fun. It's a challenge.
It certainly is. Now let's talk
Hmm.
about MIGS. You mentioned
Hmm.
that before, minimally invasive glaucoma surgery, developed by, or the term coined by Dr. Ahmed.
Hmm.
You probably know that. Tell us about what MIGS are, the pros and cons of MIGS.
Yeah, Ike Ahmed. Ike Ahmed is the OG of glaucoma up in Canada, our friends to the north. MIGS, minimally invasive glaucoma surgery or micro-invasive glaucoma surgery. So these are surgeries that are far lower than what you had referenced before was a tube, I believe. They're tube shunts or trabeculectomies. Those are the big guns. Those are the procedures that live way up here. They are invasive. and they come with a relatively high complication rate, or they can. What we're trying to do is minimize those. Those procedures can take some time too, and it takes a really, really highly skilled hand to do them well. MIGS, we have several different categories. We have our stents, iStent. iStent was first introduced, I want to say 2012. I could be wrong. It was
Correct. Yeah.
2012. All right, perfect. Off the top of my head. 2012 was the first one. And then we have our second generation iStent Inject, iStent Infinite. We have Hydrus, which is a basically what we're trying to do is increase the outflow. Increase the outflow. Glaucoma, when you really think about it, I always use the analogy of a bathtub. We've got a lot of fluid being introduced to the bathtub, and then we've got a drain. Now, in order for us to have a comfortable bath, we have to have equality between the two. We have to have enough water in our reservoir, but we want to have enough draining out, the same as we have enough coming in. If one of those is off, either we're going to have an empty bathtub or we're going to have a bunch of water on the floor. We got to have a balance between the two. So a lot of our MIGs are trying to, a lot of our MIGS devices or strategies, techniques are trying to increase outflow through what's called the trabecular meshwork. The trabecular meshwork is in the angle. It looks kind of like a sponge. And a lot of times the sponge just doesn't have enough holes in it, basically. So the thought was, hey, wait, if we just stent that, if we just put something through that, that will create better outflow. And lo and behold, yeah, it does. It works. And that's what the iStent does. Hydrus is another one, very, very similar. It's stenting the trabecular meshwork. But then we have other things too. We have non-tissue sparing minimally invasive glaucoma surgeries. These are procedures that are actually removing tissue. So goniotomy, Cahook dual blade, for instance, is a procedure where we actually take, looks kind of like a shovel, and we're removing some of that tissue. It sounds barbaric and it looks kind of barbaric if you were to look at it on the screen and you didn't know what you were looking at, but it actually is a very simple procedure, and it works very, very effectively.
And
And then we have other things. Yeah,
trabeculum, are you removing tissue?
same thing. Yep, yep. That's another version of a goniotomy, right? You're removing tissue, so it's non-tissue sparing. So lowest in the MIGS is tissue sparing. They're stents. We're not taking tissue really away. We're just kind of making a hole artificially. Non-tissue sparing, we're removing tissue. We're taking it away. We're making a hole surgically or making a hole bigger. And then we have other things like our more, I guess, more invasive, non-invasive MIGS, where our Zen, our gel stents, which is kind of like a mini trabeculectomy, where we're creating outflow from inside the eye to the outside of the eye. And then we have our big guys. We have our tubes and our trabs. So it's kind of a spectrum of strategies and techniques to go along with our disease, which in itself is a true spectrum. So picking the right category of procedure, matching it to the severity of the disease in the right patient, that takes a really keen eye and a really specialized surgeon.
What do you think about MIGS as first line therapy?
I think it's fantastic. I don't know why we wouldn't think about that if we have opportunity in front of us. I think glaucoma, we want to keep opportunity in front of us. And I tell that to patients all the time. We want to keep things in front of us, right? Let's do as little as we need while at the same time being aggressive enough. And that balance is really important. So if I have a patient, they're ready for cataract surgery, why wouldn't we take that advantage? Why wouldn't we take the opportunity to just do a little extra, 60-second procedure, maybe a little bit more than that, but quick procedure while the patient's already under and help their pressure at the same time. So it just makes sense. So I love MIGS as a first line treatment. Now, especially in mild stages, mild stages of glaucoma. Now, in more severe stages, we may need to go bigger. We may need to go from our or our tissue sparing MIGS to our non-tissue sparing MIGS, or move towards our Zens, something a little bit more, still non super invasive, but a little bit more invasive. It depends on the severity.
Let's talk about the implants that they have that can be put into the anterior chamber that have the medication in it and that is slowly sustained release, slowly released over time. Tell us your experience with that. How well does that work?
Yeah, our pharmaceutical procedures, we call those. It's kind of a newer thing. There's two big ones that we're seeing now. Number one is the iDose. which is surgically implanted. It's a very simple procedure to do. It looks similar to the eye stent, just bigger. And it has in it a canister of a prostaglandin analog that slowly releases over the course of a year or two.
And that's travoprost, is that correct?
I believe so. Yeah, travoprost. Yep, yep. So it gets implanted into the angle, just like an eye stent would. It's very simple to do. And what that's providing is slow release of medications. So for my patients that have already proven a good responder to a prostaglandin, whether it be latanoprost, travoprost, what have you, a prostaglandin analog, we can pretty safely assume that they'll respond well to that. And what we're doing then is again taking that burden away. Now, another one that is on the market is called Durysta, which is an implant. This is an implant that we put in the clinic. It looks like a syringe with a hypodermic needle. Sounds like it's uncomfortable and painful. It really isn't. Patient doesn't feel anything. It's no different than getting your flu shot. It doesn't hurt at all. What we're doing though is implanting a little pellet of I think it's bimatoprost,
Mhm.
and that sits in the anterior chamber. So these two things are both using prostaglandin analogs, the same stuff that we have in drop form, but we're bypassing the ocular surface. By doing that, we're preserving tear film. Dry eye is not a problem for these patients because we're no longer disrupting the homeostasis of the in the balance of the tear film, and we're taking away the compliance issue. So these two things are kind of newer, but are becoming much more mainstay and something that I definitely like using. I always offer this or SLT or both. There is some data to suggest that doing both actually is very, very effective. So you have two opportunities. The very simple way of putting that is both of these things should take place of one drop. So if I've got a patient who's on two drops, let's do a iDose and then let's do an SLT or the SLT then an iDose. We should be able to get them theoretically off both drops.
Now, is iDose and Durysta the same technique?
Different technique, different technique.
So
Yep.
could you explain the different techniques of implanting them?
Yeah, so the Durysta, it's a pellet. It's a free-floating pellet. So what you're going to do, you'll inject the needle temporally at the microscope. So we do this in the clinic. Again, it sounds like it's uncomfortable and painful. It really doesn't hurt. But we're going to put the pellet right in the anterior chamber. The anterior chamber is the space that's between the cornea and the iris. So it's a space that's clear fluid. It's made of aqueous. The pellet, the Durysta pellet, will sink with the use of gravity, will sink inferiorly, and it kind of nestles right in the trabecular meshwork in the angle inferiorly, and it sits there. And we have this sort of aqueous flow that's going to hold it in place. So I get that question all the time. What if I go on a roller coaster? Is it going to float around? No, it really doesn't do that. The aqueous outflow kind of holds it in its spot, and it nestles right there inferior. The iDose is a little bit different. We do this in the operating room under sterile techniques using sterile procedures. It's something that gets pushed into the anterior chamber, so it actually is implanted. Patients are under very light sedation as they would be for any cataract procedure, but it is extremely minimally invasive because we're not taking anything out. Think of cataract surgery, right? Cataract surgery, we've been doing this for decades and decades and decades. And we think of that as, at least in ophthalmology, piece of cake, right? It really is a low complication rate. We're very good at doing it. This is way easier than that because with cataracts, what we're doing is removing something. And with some of our other MIGS procedures, like our goniotomies, we're removing tissue. Well, when you remove tissue, you're naturally going to cause inflammation. And think of like if you were to get a cut on your arm, it would be inflamed. It would look red. It would scab over. It would look kind of oozy. It would be inflamed. Well, the eye's inflammation is a little bit different. The eye behaves where inflammatory cells come to the spot of inflammation, and it can cause light sensitivity. It can cause problems with your vision. The eye doesn't necessarily look that red, although it can look kind of red when it's inflamed, but it's a little bit different. So cataract surgery naturally will cause inflammation. But what we're doing with the iDose is implanting it, really not causing any inflammation at all. It takes a matter of minutes. Very, very simple to do. Again, the lowest of minimally invasive procedures that we can do.
And seeing patients that have had both the iDose and Durysta, do you see much of a difference in lowering of IOP, or would you say it's about the same?
I'd say it's very similar. I think it's very similar, and we've had good success with both. It depends on the study. One might show a little bit higher than the other, but honestly, in clinical practice, I find them both to be extremely effective. The iDose should last a little bit longer, but I think the jury's still out on how long they've lasted because we've only started doing them a few months ago. Um, but both of them have shown effectiveness and very, very well tolerated. And pressure is down, I think most importantly. We're able to get patients off drops. Again, it's a prostaglandin analog. A lot of my patients, if they're on a single eye drop, it's almost always going to be a prostaglandin. And I think we're batting about 100 at this point where we can take them off that drop, assuming things are stable.
In this study that we referenced, there were 10 ophthalmologists that gave guidance to it, and they broke it up into different stages: ocular hypertension, mild glaucoma, moderate glaucoma, severe glaucoma. Let's talk about ocular hypertension. I think ocular hypertension is very interesting because they, in the OAT study, which is a famous study that we've used for ocular hypertension that was done, I'm not even sure what year it was, probably in the early.
Early 2000s, I think, at this point. Yeah, it's been a while. Yeah.
But what happened with ocular hypertension study is that after the first part of it, after 5 years, if you did not take any drops, you were in the group that didn't take drops, 9.5% of those people developed glaucoma, 9.5, almost 10%. If you were put on drops, still 5% still developed glaucoma. Now, when they looked at 13 years out, which to me this is, almost like a lifetime, the people that do these studies think about it as lifetime. If they did not take the drops, 22% of them in 13 years turned into glaucoma, and 16% that were in the treatment group that did take drops still got glaucoma. So
Mhm.
22% got glaucoma that didn't take the drops, but 16% that did still turned into glaucoma. So I think that's a lot of proof of what we've been talking about the whole time. So the tough question is for the practitioner, for the optometrist out there, for the general ophthalmologist out there. We have somebody with ocular hypertension. They have about, after 13 years or maybe lifetime, they have about a 22% risk of converting to glaucoma. How reasonable is it to do a procedure on somebody with ocular hypertension?
Well, I mean, let me turn this question around as if you were a primary care doctor. If you have hypertension but no other risk factors, would you put, so let's say your blood pressure, typically 120 over 80 is our standard normal, right? If your blood pressure is 150 over 90, but you're an active individual, but you're 45 years old, 50 years old, would you be expecting, would you put somebody on blood pressure medication?
Most likely,
Probably.
yeah.
Yeah. I'm not speaking for a
Right.
family practice or an internist, but probably, right? And it's all about controlling risk.
Prevent stroke, heart attacks, etc.
Yeah, yeah. If you walk in, you're feeling great, right? But your blood pressure is by all guidelines elevated. You're probably going to do something about that. It's about controlling risk, and I tell that to patients all the time that we are playing odds. We are playing odds. Do you have a problem right now if you have ocular hypertension? No, no, you don't at all. But your pressure is high. You have no structural damage. You have no functional damage. You don't have anything else. You don't have any symptoms. Of course, you wouldn't if you only had ocular hypertension. I wouldn't expect any symptoms. So you have no reason to say that we need to be aggressive. But if I am you in your chair, I would treat my parents the same way, or my brother or my wife the same way. I would put you on drops, or I would do something, a procedure, more likely, something that is going to take this risk, which is non-zero, and make it even smaller. And let's do it in a very safe, effective, and easy way. Why not? And most patients really buy into that. And I tell them I try to speak to them as if they are my family all the time. And I think any good doctor does that. I would tell my mom and dad the same thing. Let's do something about this because guess what? I don't want you to have a problem down the road. I really don't. And I don't want it to be something that is going to affect your quality of life down the road. So let's be proactive. And I think patients really, really hold on to that.
In this study, their stepwise treatment progression program, number one was lasers. Number two was the procedural pharmaceuticals that we talked about, the implants. Number three was a MIGS, tissue sparing MIGS. And number four was, I guess, adding some medication. Now, where do you agree with that their stepwise approach of lasers first, implants second, mix third? Or would you mix it up and do it differently?
Well, I think doing laser first line, I mean, it depends on if our patients are surgical. So I definitely do agree with that, I think, in generality. But the thing that the paper, it does say that this is highly variable in a number of risk factors or patient's age, gender, things like that. So I think it is still, you have to take everybody in account. And that's just the truth with glaucoma. Everybody's very, very different. Every puzzle that you do is going to make a different picture, right? The puzzle. So it depends. If our patient is not ready for cataract surgery yet, if they are, let's say, early 50s, they're not at cataract age yet, but we know that if you live long enough, death, taxes, and cataracts, those are the guarantees in life, cataracts will happen. So that is an opportunity that we can, again, let's keep that in front of us. But we have a bridge. And our bridge is going to be either doing a laser first or a procedural pharmaceutical, an iDose or a Durysta. So I always, again, use those as first line. And I think that that really makes sense. Now, I think it's interesting in the paper, they didn't talk about doing drops as first line. We, as optometrists, we're taught in school. I mean, we had a glaucoma class, and almost all of it was about the different categories of eye drops and their pros, their cons, how they work, the mechanism of action, stuff like that. But it's interesting, I think, that this paper mentions drops only as kind of the end. It's the maximum tolerated medical therapy, MTMT, and or as a bridge, and a bridge between procedures. So if we do a tissue sparing MIGS, and then we need to work towards a non-tissue sparing MIGS as our next step, the drops to get the patient to that point. They only talk about it as a bridge. It's not first line, which I think is just so interesting because these are the top minds in the glaucoma world. These are the physicians that are treating the worst of the worst. And they're saying that drops should not be used as first line. And I think that's really, I think it's a unique perspective because again, the drops, all the negatives that can come from drops. Drops still have a spot. And I think in reality, in real practice, drops still do have a spot because patients aren't always going to jump on board with procedures no matter all the good stuff, all the good things that we've already been talking about for the last hour, all these good things that come from procedures and why we like to do procedures first. Not every patient's going to do that, and that's fine. That is fine. I think the take-home message in glaucoma is you have to do something. Yeah, I think you have to do something. If you have a patient who is showing visual field loss and structural damage, you can't just sit there on your thumb and think about, well, maybe I'll do something next year. Because I see that sometimes from our, patients that are referred in where, oh yeah, Dr. So-and-so said that maybe we should do some drops. And you look at the visual field and they're missing half of the field of vision. The damage is already done. So what you cannot do is do nothing. You have to do something. But that first thing that you should do, I think, I mean, we've made all the points tonight that a laser or a procedural pharmaceutical is very simple to do. Now, if our patient is this hypothetical scenario, if our patient is 68 and they're having symptoms related to cataracts, they're having glare at nighttime, problems seeing the golf ball, those types of things. Well, that's time to start talking about cataract surgery. Well, in that case, maybe we forego the laser. We still keep that on the table as an opportunity after surgery. Or there's also studies that suggest that doing a laser before surgery is actually advantageous. So that there's different ways to think about that. But if they're ready for cataract surgery, do the cataract surgery. Let's get them visually rehabilitated, and then at the same time do a MIGS.
I'm
So
very
it depends on the patient.
I'm very interested in MIGS without cataract surgery versus MIGS with cataract surgery because 90% of the MIGS are probably done with cataract surgery. But it seems there's a big opportunity to do it even way before the cataract surgery, as we were talking about with people with ocular hypertension.
Yeah, you don't have to do cataract surgery at the same time. I guess I should take a step back. We can do MIGS as standalone now. Early in 2012, that wasn't the case. When the iStent was first introduced, it had to be in conjunction with cataract surgery. Now we do have opportunity to do minimally invasive procedures as standalones. These procedures, they do take only a few minutes to do. They're very simple. And we're not, again, removing tissue necessarily. So we do have that as an opportunity. We don't have to limit it to the patients that are ready for cataract surgery. So yeah, that's a great point.
Well, something also very important that I need to ask you about from somebody that's doing this is with the procedural pharmaceuticals, the implants, insurance, from my understanding, only covers it once. And then the following year, they don't cover it. But then I've heard that, well, sometimes you can't get it covered. And that becomes very important to patients. So can it be covered? Is it covered by insurance? Is it not covered the second year, third year, fourth year? Is that a problem? In your practice when trying to get people covered the second and third year?
It certainly can be. And I think that's the elephant in the room when we talk about all of these procedures, and we really haven't highlighted that access. SLT is widely covered. That's why we use it often. And I think that's why doing a Durysta or doing an iDose, depending on access, that's the big variable that we have to discuss with our patient. What's going to be number one, available, number two, affordable. Availability, I shouldn't say that. I mean, they're always available, but accessible. And that has to do with the patient's insurance. And that's just unfortunately the US health system. That's the world that we live in. Not everything is available as much as we want to use it. So that's a very important piece of this puzzle is what can we do for our patients? Same with MIGS. Some things are going to be better covered than others. And then again, back to our pharmaceutical procedures, what happens when we need to repeat it? And we haven't had to repeat them yet because again, we're relatively new doing them in our clinic. We're going to cross that bridge down the road at some point, and we'll find out. We've been reassured by our reps, and I think any optometrist or anybody who's listening that is seeing patients, I think staying in good connection with your local reps and with the companies, they will help you. Right? They will help you go through all of the hurdles, all of the red tape that exists with getting these approved, all the prior authorizations. They are extremely valuable resources, and they're huge advocates for both you as the physician trying to do these and also your patient. So get to know your reps, and when they come into your office and they want to talk to you, don't hide. I think that's what a lot of docs do. They hide. I always run up front. I want to talk. I want to talk because what they want to hear, they don't necessarily want to hear that everything is rainbows and gumdrops. They want to hear where the problems are and how can they help. So I think having the relationships with the local reps is just super, super critical. Because when we do need to repeat these procedures, inevitably we will. The iDose only holds so much of the medication, and the Durysta eventually dissolves. So eventually we're going to have to repeat it or cross that next step. They're going to be the ones who are going to help us get it approved. And so I think that is the big elephant in the room. All of these procedures have to be approved. They have to be affordable. Um, but something is. Again, very, very, very basic level. You got to do something if you're treating glaucoma.
We talked about ocular hypertension, about if we talk about mild, moderate, and severe glaucoma, is there much of a change in in the way that they're going to be treated in the steps and how you would pick the steps?
Yeah, it comes down to just how aggressive you're going to be from a treatment standpoint. Our mild glaucoma, we're going to start with our lasers. Same with moderate. We usually start with our lasers, and that's what the article has suggested too. And then we're going to use procedural pharmaceuticals in conjunction with that if needed. We then progress pretty consistently between both mild and moderate. We're going to go to our tissue sparing MIGS and then our non-tissue sparing MIGS. We don't typically get to filtration surgeries with mild glaucoma. Mild glaucoma doesn't really have a significant amount of visual field loss. It's relatively mild with RNFL loss. And so the need for filtration surgeries is usually only with moderate glaucoma. Even if you have pressure that seems to be elevated, by definition, we're not showing a severe or a moderate to severe disease state. So the need for these bigger, more aggressive procedures, we just don't have to get there. And so that's the big difference in the treatment paradigm between mild and moderate. Now, talking about severe, that's different. Severe, we have to be more aggressive. We're doing more procedural pharmaceuticals earlier. Our tissue-sparing MIGS are now more first line. And then we're going to jump to our non-tissue sparing MIGS, so our goniotomies, those types of procedures. Then we're going to continue doing drops as needed with lasers, and then filtration surgeries are definitely a more realistic endpoint for severe glaucoma because when we manage severe glaucoma, we want our pressure, our target has to be lower. We have to be aggressive. We have to have our foot all the way down on the gas. We want to do everything we can because we're dealing with a significant loss of RNFL cells. We're dealing with a significant loss of permanent structural damage. So we are really behind the eight ball in those patients. And that's where we just have to be more aggressive.
Now, the challenges associated with interventional glaucoma, as far as in the doctor's office, clinic flow, hesitant, the physicians being hesitant because it's something new, and the staff being hesitant, the training that's involved in it. Uh, if you could speak to that, of a glaucoma practice out there, if this is something they want to do, talk to us about those points.
Well, I think spinning that question around or spinning that point around, is it more burdensome on the staff to be dealing with prior authorizations and pharmacy phone calls with eye drops? Is that more burdensome? Or is it more burdensome to train the staff to understand what to do with these procedures? I would strongly argue that it's easier on the staff for procedures. Our staff is very well trained. But if I have drops, if I'm calling in drops specifically, a lot of times name brand drops can be harder to get, but we always like to use name brand drops if possible. We just know what's in them. We know how they're produced. There's a lot of reasons why we like name brand. However, a lot of name brands sometimes come with less coverage than they can. And we have one dedicated staff in our office that is constantly filling out. He's doing prior authorizations for us. He's on the phone with pharmacists, on the phone with patients. It is just a ton of man hours being wasted with clerical work, with work that, is it's important. We need it. But his time could be used better doing stuff with patients. He's a very skilled individual, and we use him. He just knows how to do it. It's such a waste of man hours. Now, alternatively, if we're doing procedures, training somebody how to handle these procedures from a staff point of view, we train them once. They understand how to do it, right? Where we don't have to constantly change based on the restrictions that exist. You teach a man to fish, he eats for a lifetime, right? Or if you give a man a fish, he only eats for a day. We train them once and they understand what patients go through, and then they understand how to handle these patients and, the complaints that patients come in with any procedure. We start hearing them and we start putting patterns together. So I'd say that it's less burden significantly on the staff for these procedures.
How about on an OD's practice? Talk about that.
Well, I think it's the same point of the same mindset. All
You
right,
know,
one second. Let's get a little
one of the problems that we have as ODs, I mean, a lot of times the insurance companies want us to use inferior medications. We want to use one medication, we want to use a branded medication, but they're pushing a generic that may not be as good as a branded medication.
all the time, all the time. And that's incredibly frustrating. You know it as well as I do. I mean, that's incredibly frustrating where I'm putting a patient on, again, the name brand. We always want to go with name brands. We generally do. But then I've got a pharmacy calling me saying, well, hey, have you tried this instead? And a lot of times, well, no, I didn't try that because that is noted to be inferior to what I tried or what I want to use. And so you've got the insurance companies now dictating what we're doing as physicians. And that is just it's incredibly frustrating and let alone dangerous, right? Because now our patients are getting the care that is below what I would deem to be standard. Now, the procedures, there's no alternative to an eye stent, really. I mean, eye stent is unique in that it is specifically what it is. Now, there are different types of ways to bypass the trabecular meshwork, but an eye stent is an eye stent. A hydrus is a hydrus. An iDose is an iDose. A Durysta is a Durysta. These are all unique things. And so we don't run into those issues nearly as often. Now, the issue that we run into is it going to be covered at all? And then that's frustrating too. And again, that's still the elephant in the room with interventional glaucoma or procedures in general. We still do have the third party payer somewhat dictating what we do, but they aren't replacing something. They aren't changing a treatment strategy kind of behind my back. And it's more out in the open, and we have still more, from a physician point of view, an active role in what is being done if something's not covered.
And for the ophthalmologists listening, if they want to be more interventional, what kind of training can they get so they could be more interventional?
I think listening to the podcast is a start. Just I think adopting the mindset and changing your way of thinking. I think you got to start that. I talk to students. We have students come through our practice every semester, and I talk to them all the time. Get comfortable being uncomfortable, because if you're comfortable being uncomfortable, you're learning. You are naturally learning. So change and constantly challenge your way of thinking. Be open to new ideas and think critically for yourself. Is this idea a good one or not? You don't have to agree with the interventional glaucoma consensus paper. You don't have to. At least be open to it as an idea. And I think that's the start. So being open to new ideas, changing how you think about things. And then how do you learn how to do things? If you're looking to learn how to do iDose, contact Glaukos. Contact Glaukos. I mean, they'll get somebody out to train you right away and get you certified. What if you want to do SLT, or the new SLT that we haven't talked about is the DSLT, the direct SLT, which takes seconds to do. How do you want to learn how to do that, or do you want to get one of those? Well, they'd be happy to send somebody out right away. There are ample resources. You just got to ask.
And what should the patient expect? They're being referred by the optometrist. What should they expect about when they're being referred for interventional glaucoma?
They should expect that their best interests are being taken into account. Any optometrist is referring somebody to. I like to think that I have a relationship with all of the doctors that refer to us on some level. And we have these relationships because I've shaken their hands, I've had dinner with them, I've talked to them in social settings, and we have some sort of respect for each other, at least mutually. And the same goes for my partner, Dr. Vukic, my surgeon that I work closely with. We have relationships with people. They're not sending patients to us necessarily because, our building is the shiniest, or they're not sending patients to us because, they like the name of our practice, Summit Eye Care. It's because of the personal relationships. So I think patients who are being sent for procedures have to understand that they're being sent for a very, very specific reason. Now, whether it be skill or technology available or just personal relationship, there is always a reason. And again, you as the primary care optometrist know these patients better than the referred to surgeon, or us as the secondary care staff. You know those patients better. And if you know your optometrist as well as I hope that you do, your optometrist probably would send their own mother or their own father to the same doctor. And I think that's the question that you ask them if you're a patient listening to this. Where would you send your mom? If they say Dr. X, you know that they have your best interest in mind.
Now, from you have a lot of experience. You've had patients that have been on drops for many, many years. You've had patients that have gone through procedures. Tell us which patients seem to be happier.
The ones who can get out of their drops. I think the ones who, when we specifically outline what we're trying to do. I think there's an expectation. We always want to set expectation, no matter what procedure we're doing, whether it be a cataract or a LASIK or a MIGS procedure. The expectations have to be outlined. And specifically for glaucoma, the expectation is not that your vision is going to get better. But we always want to put a number. What we're trying to control with the procedures is your pressure, and then indirectly your optic nerve damage. So we're not going to see RNFL improvement. We're not going to see improvement on the scans, but what we can see is your pressure go down. So I think the patients that are happiest are the ones who get a good response. They're always our glaucoma patients always, they're it's almost like shooting for a high score, like at the arcade. Like I want to get my pressure as low as I possibly can. They're naturally really happy. But it's the ones they feel like they're being heard and they feel like they are taken care of. I think those are the ones that are really the happiest because, again, they are in a vulnerable spot. Anybody who comes through our doors, I know they have a little vulnerability to them because they're nervous. And that's natural, right? we're dealing with the most valuable human sense, the most valuable human sense. Patients, if you ask them, would you rather lose your taste, touch, hearing, eyes, or smell? Nobody wants to lose eyes. Eyes are so valuable. So they're nervous, that's normal. That's understood. And so we always want to make sure our patients understand that what we're doing is in their best interest, and we're going to take every possible opportunity that we can to make sure that we're doing things in the right way and safe and in their best interest. And I think those are the patients that are just happy. They just feel taken care of.
And how long has it been since your practice has changed their approach to become more procedural?
We started this way. So our practice is kind of unique. We started in January of 2020 cold. I joined Dr. Vukic. I moved from Michigan. He was at a large clinic in Madison, which is about an hour west of us. And we wanted to build a practice in a way that valued the patient experience. And so that was the pillar of what we were trying to build. Procedures with a high touch, a high level of touch. Now, January 2020, as you know, was probably not the best time to start a practice. That was, in hindsight, wish the timing would have been better, but it worked out fine. And I think proof is in the pudding. If you do good stuff, you treat patients well, and you've got their best interests in mind, the practice has grown, and we are very, very, we're self-sustained now. I mean, this is 5 years later. We are doing very well, and we're busy. And it's just because I think we value the patient experience. And so, yes, this is something that we have not changed our way of thinking. This was from day one. We are going to be procedure first and develop the relationship with our community.
This has been an amazing conversation, Dr. Bruns. Is there anything that I didn't touch on that you think that we need to tell the audience?
I think the audience, whether you're a patient or a doctor or a surgeon, anybody, or a family of a patient, be open to a new way of thinking. Just because it's a procedure maybe being presented to you as a first line option does not mean that it's scary. In fact, a procedure might be more conservative than eye drops because of all the negatives that come with eye drops. Procedures might be the safest way to proceed in management of glaucoma, and oftentimes they are. So be open to your way of thinking. Make sure you expand your horizons. You continue to learn, whether it be a patient or a doctor. I always encourage my patients to do their homework. If you want a second opinion, get that second opinion. That's fine too. There's no harm in that. I always encourage patients, if you want a second opinion, that's totally fine. My feelings are not hurt. I always encourage you to at least read. The internet is a valuable spot. It can also be a terrifying spot. Make sure you're getting good, valuable resources. And I'm happy to provide patients with data points, the LIGHT trial, the OATS study, all of these big trials that were done and that are peer reviewed. I'm always happy to provide those for patients. So make sure you're doing your homework, but just make sure you're doing it, with proper resources.
Dr. Nick Bruns, you're a brilliant doctor. I want to thank you for joining me today on the Open Your Eyes podcast with Dr. Kerry Gelb. Thank you so much.
Thanks for having me, Kerry.
Thank you, Nick.
MacuHealth is a nutritional supplement leader. Our targeted formulas include MacuHealth for daily eye health, MacuHealth Plus for aging eye support, Vitreous Health for vitreous care, Vision Edge Pro for visual performance in athletes, TG Omega-3 for ocular and systemic wellness, and MacuHealth DM for eye and metabolic support. Call MacuHealth today and mention this podcast for special discounts. Experience the difference with MacuHealth. Nutrition you can see.